worry about measuring this. And it'll give you basically the predicted cylinder based on an adjustment on the posterior cornea, and also an adjustment with the effective lens position based on the IOL power and what you've entered in your variables, including axial length and keratometry and anterior chamber depth. Now, there are, of course, other ways to directly measure the corneal curvature, measuring the anterior and posterior corneal curvature. For example, this patient you see has 2.65 diopters on topography. When we look at their posterior cornea, we see this patient here, you see on an absolute level has about 0.6 diopters on the posterior cornea. So you can see that even though they have 2.6 on the anterior, we have to also consider they have posterior as well. And of course, there are different ways we can calculate this. Same thing with the pentacam. We can get values, measure the anterior cornea and posterior cornea. And of course, we have to not only just take the difference arithmetically, we have to also consider Snell's law. We have to consider the axis as well. So I think that for many of us, we are using some of these devices that measure the anterior and the posterior cornea to give us basically the net corneal power, or what's also called the total corneal refractive power. So these are all different ways that we can do this. Now, of course, we know we can get the right IOL measurements, the right cylinder, but if we don't get the right toric alignment, we know, of course, for every degree we are off, we lose about 3.5% of the effect of our astigmatism correction. So the goal is to be exactly on. And in the old days, and maybe some of you are still doing this, we would put the marks on the cornea with the patient sitting up, 3 marks on the cornea or 2 marks on the cornea at 3, 6, and 9, and then use an axis marker intraoperatively. And there's, of course, many different markers that are out there, nice Mendes rings. You can align up where to put the marks based on your reference marks. Here, for example, we have marks at 6 and 12, or 3, 6, 9, and 12. You can see, by the way, look at patients lying down, and even though we've marked them at 3, 6, 9, and 12, look at the cyclotorsion. This is why we always have to consider, when we mark the patient at least, how they are in the sitting position. When patients lie down, of course, then they get some typically cyclotorsion. And there are now some nice newer techniques, for example, using this one-step marking, which I personally use, which is basically a rotatable head with 2 rays, 2-ray marker. We can rotate the marks exactly where we want on this dial. So for example, if we want to be at, let's say, 30 degrees, and then using a plumb bob with the patient sitting up, we basically can mark the cornea with the patient looking to me in sitting position. So it's already marked at the correct axis. This is simple, it's easy to do, the technology is not that expensive, and it shows the mark quite nicely here on the cornea, so we can line up the axis quite well. And you see, by the way, I did not use ink. You know, ink gets messy. The ink spot itself is 5 degrees or more. So simply pressing on the cornea with a nice beveled indentation marker, you can see the marks show up even for 30, 40 minutes after the case, for those of you who take a long time for surgery, by the way. And you can see now with the cornea dry a bit, we have a nice position here as well. Now certainly, of course, it's exciting now because we are now in the age of image heads-up display, right? This is me driving in Canada. I'm in 4th gear, as you can tell, right? I'm going 152 kilometers. Who knows why I am driving 150 kilometers on the highway? Who knows why? Anyone know why? If you know why, I will give you my laptop. Free. Come on. I was, yes, you're right about that. Like this morning? Okay, thank you. Thank you for reminding me I was late. Thank you for doing that, yes. Well, in Canada, we have a law. If you are caught speeding at 50 kilometers above the speed limit, you get your car impounded for 1 week, license suspended for 1 month, and about an $800 fine. So in Canada, the speed limit on the highway is 100 kilometers. So I make sure I just go 152, so that way I can always argue I'm just under the threshold. That's why. So I should go 149. This will help me protect me, right? You know. Anyways, we actually have some pretty fancy technology that gives us this ability during surgery now to have heads-up view with a digital markerless system. Zeiss and Alcon both have systems. And these are integrated, for example, with the IOL Master. You can basically plug in the details in the system. And basically, you can see reference marks are taken by the IOL Master using limbal acquisition and scleral vascular registration. And using these scleral vessels, the same scope on the microscope can then use it to align these images. So here, for example, we've entered the data on the USB stick or network. We choose the patient information, we import it in there, and there's our data. We can then basically choose our incision position. We can basically choose to, for example, center the capsulorhexis on the visual axis at the right size, whatever we want. We can then choose our axis of the toric lens, 19 degrees here, and set all our values up. Now look at, this is the important step. This is basically the registration process. We take the preoperative image and match it with the intraoperative image so to make sure that the landmarks are lined up. It does it automatically. You see pre-op and intra-op, side by side. So now the machine is locked in on the eye, so we know when we do the procedure that we actually will be lining up where we should be. For example, take this case where you see I have the incision at 180 degrees, and even though the eye may be moving, even though there's rotation, cyclotorsion, movement, the microscope and the technology is moving with this and aligning it accurately. We can set a 5.5 millimeter rexus if we wish, and proceed with the phaco. There's a lens going in, and now you see the toric alignment tool here being used to line up the lens, and of course we go underneath the toric lens to remove viscoelastic to avoid rotation, and we can line it up nicely, and basically we are using this advanced imaging system to help identify the marks. Now you could also see that actually that my marks on the cornea were actually very similar on the same axis, and we see some studies being published showing that there's pretty good correlation. But this does enhance the workflow. Also, I can use it for centration of the lens by the visual axis as well. Now, Alcon has a very similar system, a built-in keratometer and image registration system. So preoperatively, the image is taken. And then intraoperatively, we can enter the details imported from the patient's preoperative testing. This is basically, of course, using video injection. So they basically, the microscope has the built-in video injection, very much like, for example, the neurosurgeons use. And we can basically line up the incisions, do capsulorhexis again, line up the toric lens as we wish to do it as well. So these are all very fancy technologies that allow us to do that as well. So I think there still are questions. Is it worth the cost? Is it worth the value? I think these are all good questions. I think if you have a good toric marking system, you can probably do pretty well without it even. But this, of course, helps with the workflow, reduces the potential for error as well. And of course, we have heard a lot about intraoperative aberrometry as well, using an aphakic refraction, for example, with the, in this case, with the Verify system, the Aura system here, allowing you to select the lens and allowing you to essentially then align a toric lens. Here, as you can see, is an aphakic refraction being taken, and you see that we can look at the astigmatism present here. As you can imagine, it's very important to keep the pressure in the eye at a set level, so you don't overpressurize the eye. It's important as well to avoid any external pressure from the speculum. This will give you then and identify what the IOL power would be on aphakic, match it up with your selection preoperatively as well. And then once the lens is put in, you can see the lens is in. The machine is telling us to rotate the lens a bit counterclockwise. Once we have rotated into a position we feel is neutralizing the cylinder, we can then capture here. And once we capture, we see that basically the residual cylinder is minimal. So intraoperative aberrometry, I think, is a very interesting phenomena. I think that for me, there still are questions, again, of cost effectiveness. How much does it make a difference in terms of our IOL selection? What's our inventory like? Do we have all these IOLs in our inventory? You have to have different spherical powers, different cylinder powers, and pick them on the table. And even knowing all this, of course, the one thing that's missing is the effective lens position. We don't know this, of course, in an aphakic eye, simply by doing aberrometry. Now, for toric alignment, it's interesting because you have a lens in the eye. It may be helpful to rotate, but also corneal incisions are still there. They will heal. The cornea is hydrated. So there are different values, I think, that are still present that are uncertain. So let me finish up by saying, what do you do after all these things and the patient still has a diopter of astigmatism post-op? What do we do then? They paid for the lens. Your referring doctor is saying, you promised them they're going to have no cylinder. Why do they have a diopter left? There are many reasons why, which we talked a little bit about as well. My general rule is this. First of all, what is a spherical equivalent? Spherical equivalent is near plano. Then I can either go back in and do an LRI, which means don't go into the eye, of course, or rotate the lens. My basic rule is if they have more than a diopter of cylinder, I usually go back into the eye. But if they're less than a diopter, then doing an LRI, which I think is quite reasonable to do, and I do it with the slit lamp, and I'll show you a video of that, is useful. If the spherical equivalent is off, though, so even though they have astigmatism, they also have myopia, then we have to think about, do we do an exchange or laser vision correction are the options. If we decide to rotate the lens, we can use refractive versions formulas in the astigmatismfix.com by inputting the known lens, what axis the lens is at, and then basically it'll computate for us what the new axis should be. So the current toric position you see is here. It's at 155 degrees. The formula is saying rotate the lens here to a better position of 15 degrees to neutralize the cylinder. Don't assume you're going to rotate the lens back to the original axis you calculated preoperatively. Because again, things have changed, the astigmatism has changed postoperatively. Now, if you can go back and rotate the lens within, a month after surgery, this can be done using a technique that does not require visco injection. Now, of course, we inject viscoelastic in the anterior chamber, but here we're very carefully lifting up the capsule with a pair of microforceps while basically pushing back on the lens to free it up from the anterior capsule. There you see this. There's minimal reaction here, and by doing this, basically, we can essentially separate the lens from the capsule. And sometimes there's a bit of pushing and pulling a little bit, gently, to essentially simply release the plastic polymer lens here from the bio tissue, of course, which is the capsular bag here. Now, of course, if I was struggling, I would use viscoelastic to visco-dissect, but you can see here, as long as I have OVD in the anterior chamber and the eye is stabilized, we can basically liberate the haptic. And the same thing on this side. Now, why am I doing this without viscoelastic? Well, of course, one of the reasons why lenses rotate, if they weren't marked wrong, is because OVD left in the eye may result in the lens moving because the lack of adhesion early on. So doing it without viscoelastic for me is an advantage because we can do this and really expect the lens to stay put where we end up being there. Now, if we are unable to, or if we decide the patient has just a little bit of astigmatism left, then using a marker like this and using a slit lamp blade like this allows us to perform slit lamp LRIs, which for me is one of my favorite things to do because it's a very easy thing to do at the slit lamp. You see, basically, we've made 30-degree arcs here. I've made my mark here on the steep axis, or the steep axis of the refractive cylinder. Remember, we're treating the refractive cylinder, not the keratometric cylinder here. And we have different marks here depending on how many degrees we want to make, depending on the amount of cylinder. And here you see the marker being placed on the eye. This patient here, you can imagine, probably has some width the rule cylinder, you'll see. And there's the mark. Each mark here gives us about 15 degrees, 30, 45, 60, depending how much we want. We then follow the mark. The treatment zone is about 10 millimeters. And it's a very simple thing to do. Now LRIs are basically quite a bit of art, maybe less science. I typically treat conservatively, and we can, of course, treat more as we have to do this. But anybody, again, any of us treating astigmatism will always have some patients who come back who have residual astigmatism that we need to treat. And instead of taking them to the OR or doing femto laser or, rotating the IOL, this is a very useful technique. And I have the special blade here that we use. It's a diamond blade that we can nicely use to create these curvilinear arcs. So we've covered a lot of different things about astigmatism. It's something I think that is fairly easy to treat, but does require a fair amount of thought. And we've got great technology preoperatively. We've got great marking systems. We have intraoperative guidance if we decide to use that. And of course, we have other options to treat these patients if they have residual cylinder afterwards as well. So keep on working hard to treat astigmatism, and I hope those are some important pearls to help you with tackling those difficult cases. Thank you. Tranquila, tranquila, yes. Okay, how many people treat intraocular tumors? Intraocular tumors. Perfect, okay, good. You have more hands than I had, so.
Thank you, Dr. Ahmed. Vamos a continuar con la charla del Dr. Villanueva, tumores intraoculares, diagnóstico ecográfico. Y luego, para finalizar, el Dr. Ahmed va a hacer un mix de las dos charlas que le quedan, que es las innovaciones en la cirugía de catarata y lo extraño de la cirugía de catarata.
Listo. Vamos a empezar con la última placa que me tocó el día de hoy, como diagnóstico ecográfico de los tumores intraoculares. Prácticamente lo que ocupamos para el diagnóstico de tumores intraoculares es la clínica. Posteriormente a la clínica nos podemos apoyar con los ultrasonidos estandarizados o los ultrasonidos B convencionales, no es únicamente para valorar las diferentes posibilidades diagnósticas que tenemos para un solo tumor. Los ultrasonidos están indicados para ese tipo de diagnósticos apoyados por medios ultrasónicos, determinar los tamaños y evaluar el crecimiento tanto pre-tratamiento como posterior al mismo si es que lo tiene. Ocupamos la ecografía estandarizada, imágenes en terceras dimensiones, y podemos llegar a ocupar lo que es la ultrabiomicroscopía ultrasónica y en algunos casos el Doppler. Para que tengamos un entendido, más o menos las lesiones que tengan un grosor mínimo de 0.65 milímetros van a ser evidentes por medios ultrasónicos. Lesiones en el cuerpo ciliar mayores a 1 milímetro, igual que lesiones en iris, y en cuerpo ciliar mayores a 1.5 y con elevaciones mayor a 0.2 milímetros. La exploración es una exploración oftalmológica convencional por medios ultrasónicos mediante cortes longitudinales, transversales o ubículos, axiales, dependiendo de la zona en la cual queramos examinar. Hacemos un recorrido desde anterior hacia posterior, variando todas las secciones con los cortes transversales y longitudinales para evaluar tanto bases como amplitudes o elevaciones de las tumoraciones. Esto lo hacemos tanto con el ultrasonido B como con el ultrasonido A. Aquí lo estamos haciendo con el puro ultrasonido A, igual de anterior a posterior, y hacemos totalmente los escaneos. Como lo muestra aquí el esquema, hacemos un corte estandarizado, preferentemente identificando la lesión en forma clínica. Hacemos un corte exactamente en el mero centro de la lesión. Y posteriormente a esto hacemos cortes anteriores y luego posteriores, a fin de determinar la elevación máxima de la tumoración. Y con el modo B, hacemos cortes transversales para determinar la posición, el meridiano y el tamaño de la base. Vamos a comenzar con las tumoraciones más comunes que podemos llegar a encontrar, que es el melanoma coroideo. Por lo general son masas sólidas que tienen una forma en domo, son lobuladas, con una estructura regular interna, con un flujo sanguíneo interno presente y tienen una configuración que pueden tener una forma de cuello de botella. El modo A presenta reflectividades de medias a bajas. La forma más frecuente que podemos llegar a encontrar es la forma en domo, pero también la podemos encontrar en forma lobular o la clásica forma en champiñón, donde ya tenemos una excavación coroidea y una atenuación acústica posterior. Va a haber atenuación del sonido posterior, va a haber excavaciones coroideas, inclinaciones esclerales, puede haber hemorragias vítreas secundarias, hemorragias subretinianas o desprendimientos de retina exudativos secundarios. En tumoraciones tan grandes podemos encontrar rupturas de lo que es la membrana de Bruch, y esta es una ecografía estandarizada donde determinamos la posición de la lesión, vemos el tamaño de la lesión y por medios ultrasónicos valoramos la reflectividad de la misma, donde encontramos un pico amplio de reflectividades altas iniciales que correspondería a lo que la retina y el inicio del tumor, y en su interior podemos encontrar reflectividades medias bajas. Muchas veces cuando estamos haciendo el estudio en forma cinética en real, aquí podemos llegar a detectar una zona que se llama flicker, que es una zona en la cual podemos ver la vascularización que tiene el tumor en su base. Cuando llegamos a tener presentes ese tipo de lesiones en la cual hay una concavidad posterior, esto quiere decir que ya tenemos algún tipo de toma o algún tipo de infiltración a nivel escleral. Eso es muy importante para determinar la progresión que tiene ese tumor. Si hay esto, quiere decir que hay infiltraciones esclerales secundarias. Puede presentar, como ya he comentado, desprendimientos de retina serosos secundarios a lo que es el margen de la lesión tumoral inferior. Y lo podemos ver aquí. Si se dan cuenta, en el estandarizado modo A se van a ver dos picos. El primer pico correspondería a lo que es la retina. Inclusive es una línea de reflectividad alta que sube y tiene una descendencia hasta la línea base y luego vuelve a subir otro pico. El primer pico correspondería a la retina y el segundo pico correspondería ya a lo que es la parte anterior de la tumoración. Vemos la conformación del tumor en la parte interna y la zona de lo que es prácticamente la esclera. Únicamente aquí se representan las hemorragias retinianas secundarias. Aquí está el tumor y tenemos una hemorragia vitrea secundaria. Y puede haber algunas conformaciones atípicas de las tumoraciones, como pueden ser estas. Esa es una lesión en domo, en hongo prácticamente, donde aquí lo que únicamente estamos ejemplificando es que aquí se alcanza a ver lo que es la membrana de Bruch. Si se dan cuenta, en el modo estandarizado se ve un pico de alta reflectividad que correspondería a este. Y vemos aquí la membrana de Bruch, otra reflectividad media alta que correspondería a esta membrana. Y cuando esta membrana llegara a estar totalmente falta de la continuidad, o sea, rompe la membrana, no encontramos este pico en ese tipo de lesiones. Puede tener también espacios quísticos, es lo menos frecuente. Puede haber datos de inflamaciones a nivel subcoroideos e inclusive puede tener calcificaciones. Estos son algunos patrones atípicos, pero puede llegar a presentar. La diferenciación del tumor puede ser con todo ese tipo de tumoraciones, pero la diferenciación más importante es con el melanocitoma. Clínicamente se ven muy parecidos, pero ecográficamente son diferentes. Podemos tener en el melanocitoma reflectividades igual altas iniciales, pero prácticamente la tumoración en su cuerpo o en su interior sigue siendo de reflectividad alta. Entonces, este es un diagnóstico muy importante de diferenciación en cuanto a un melanoma y un melanocitoma. El segundo es el carcinoma metastásico. Es prácticamente una lesión elevada, puede ser muy irregular, de color amarillo, es difusa, se encuentra por lo general en el polo posterior, puede ser focal o puede ser multifocal, inclusive puede ser lobulada. Esto por lo general es secundaria a antecedentes de cáncer de pulmón en hombres y a cáncer de mama en las mujeres, donde vamos a encontrar lesiones difusas irregulares en el polo posterior, de una reflectividad media a alta y totalmente irregular. Aquí lo podemos ejemplificar en el estandarizado, donde podemos ver la primera parte de la lesión, que correspondería a un desprendimiento de retina secundario. Si se dan cuenta, la primera línea correspondería a la retina y la parte posterior ya correspondería a lo que es la parte del tumor. Entonces tenemos un desprendimiento de retina secundario con una tumoración que es de conformación irregular, de reflectividades altas. Si se dan cuenta, los picos de la lesión nunca llegan a la línea base y se mantienen en una reflectividad alta, como se puede ver aquí. Los hemangiomas coroideos son lesiones igual, son un poco menos irregulares que el carcinoma metastásico, tienen forma de domo, también pueden tener forma de placa, las reflectividades son prácticamente altas y no encontramos vascularización. Si se dan cuenta, la conformación estandarizada de lo que es el hemangioma coroideo y el carcinoma metastásico son básicamente bastante diferentes. En el metastásico, si se dan cuenta, las lesiones pueden llegar a bajar por debajo de la línea media. Nunca llegan a la línea base, pero sí por debajo de la línea media. A diferencia de los hemangiomas coroideos, nunca bajan o nunca pasan la línea media. Siempre son reflectividades altas consecutivas. Los nuevos coroideos son lesiones benignas a nivel del polo posterior, donde podemos encontrar lesiones bien conformadas o lesiones elevadas, no mayores a 2 milímetros de la pared posterior, con una reflectividad alta, y por lo general suelen ser periféricas. Lesiones dififormes a nivel macular, que son lesiones totalmente irregulares, puede haber en forma en domo y la reflectividad tiende a ser alta. Prácticamente la estructura es variable y aquí se dan cuenta la conformación es diferente. Tenemos una lesión irregular anterior de reflectividad media alta y prácticamente todo el contenido de la lesión es una lesión media a alta, pero que llegan y sobrepasan la línea media de la lesión. Las hemorragias coroideas son lesiones a nivel de la coroides, tienen por lo general forma en domo, presentan, si se dan cuenta, es una característica muy importante de esto, presentan un pico de reflectividad alta y si se dan cuenta, tienen una doble espiga, como si fueran dos orejitas. Esta es una conformación muy típica de lo que es coroides. Lesiones de reflectividad alta con doble pico, con dos espigas y en la conformación interna pues puede ser prácticamente, como se ve aquí, una reflectividad baja interna. Inclusive puede haber reflectividades anecoicas, en donde pueden ser desprendimientos coroideos serosos. Y posterior a esto ya encontramos a lo que es la esclera. Por lo general, esas las encontramos hasta antes de lo que son las lesiones vorticosas y nunca llegan al polo posterior. Por lo menos no la inserción. Los osteomas coroideos son lesiones blanca-amarillentas, pueden tener también una coloración naranja-rojiza, se encuentran en la región peripapilar, por lo general son en mujeres jóvenes, tienden a ser unilaterales y focales y la reflectividad tiende a ser alta. Si se dan cuenta, en el modo B vemos una lesión en placa con una brillantez bastante importante y por detrás de la misma encontramos una sombra acústica posterior bastante importante, que sería sombra acústica. En el modo A vemos igual, es una lesión de reflectividad muy alta y si se dan cuenta aquí no hay ángulo capa. Esto quiere decir que hay una atenuación acústica importante. Al no ver un ángulo capa en ese sector, quiere decir que aquí se absorbe el sonido y cae abruptamente la propagación del mismo. Esos son datos clínicos muy sugestivos o prácticamente diagnósticos de un osteoma coroideo. Y así como se encuentra esto, también puede haber lesiones a nivel del disco óptico. Hay calcificaciones esclerocoroideas idiopáticas, retinoblastomas, angiomas retinianos, amartomas astrocíticos, drusos del nervio óptico. Todas esas pueden tener calcificaciones. Aquí tenemos un cuadro de lo que acabamos de mencionar. Eso lo van a poder tener ahí en las presentaciones para poder diferenciar las diferentes tumoraciones más frecuentes que podemos llegar a presentar en el consultorio. Otra tumoración más frecuente es el retinoblastoma. Esto por lo general es a nivel unilateral en pacientes pediátricos o bilateral en pacientes pediátricos menores de 1 año de edad. Pueden ser focales o multifocales. Es una lesión blanco-amarillenta, preferentemente de color blanca. Y la que caracteriza este tipo de lesión, este tipo de tumoración, son las calcificaciones en su interior. Vamos a encontrar lesiones en masa que involucra la retina a nivel subretiniano, y vamos a encontrar lesiones puntiformes en el interior de la lesión. Puede tener lesiones quísticas y son lesiones cálcicas que pueden tener sombras acústicas posteriores e inclusive también desprendimiento de retina secundaria. Como lo podemos ver aquí, aquí tenemos la masa, bajamos un poco la ganancia del ultrasonido y alcanzamos a ver las lesiones calcificadas típicas del retinoblastoma. Y aquí con atenuación acústica posterior. En el modo A se va a ver muy similar. Es una reflectividad interna alta, arriba del 70-90%. Si nosotros al ultrasonido estandarizado pasamos e incidimos en el tumor y le ponemos configuración de tumoración, vamos a tener esto. Vamos a encontrar la lesión y exactamente para qué Rita va a decir reflectividad interna y te va a poner un porcentaje. Va a poner un porcentaje 30, 40, 50, 70, 80, 90, dependiendo por dónde esté incidiendo. Cuando son lesiones con ese tipo de tumoración, te va a poner una reflectividad de arriba del 80%. Son de consistencia sólida, no móviles, no hay postmovimiento. Si se dan cuenta, igual el ángulo capa posterior no es decreciente, sino es totalmente, no existe. Eso es por la absorción del calcio que tiene el tumor. Estas son las tumoraciones son las patologías que tenemos que descartar al tener un retinoblastoma. Todas se pueden hacer también por medio ecográfico. Las tumoraciones del segmento anterior las podemos hacer igual por medio B estandarizado, por inmersión o por medios de ultrabiomicroscopía ultrasónica. El día de mañana tenemos una práctica de VM donde vamos a ver imágenes específicas de ese tipo de lesiones. Pero hablando un poquito, el melanoma de iris son lesiones que se encuentran a nivel de la pupila o el ángulo a la extensión. Tienen forma variable, por lo generalmente irregular a nivel de lo que es el estroma iridiano, y la reflectividad tiende a ser media y presentan vascularización. Por lo general son lesiones que por lo general son pigmentadas. Aquí estamos viendo una ecografía modo B estandarizada por inmersión. Si se dan cuenta que está el medio de acuoso que usamos, aquí está la córnea, y aquí llegamos a encontrar a lo que es la lesión. Prácticamente es una lesión de reflectividades altas o de alta brillantez, que en el modo estandarizado, aquí encontramos lo que es la córnea, la cámara anterior, y la reflectividad que se ve aquí es una reflectividad media alta. Melanomas del cuerpo ciliar son lesiones que se encuentran en domo, de baja a media reflectividad, son vascularizadas, donde hay un crecimiento atípico de lo que es el cuerpo ciliar. Por lo general, cierran a nivel angular en ese sector, por protrusión del mismo iris hacia adelante, y cierra ángulo secundaria. y también podemos llegar a encontrar la reflectividad, que puede ser media baja, y si dejamos el transductor aquí podemos ver vascularización de la misma tumoración. Muchas gracias.
Muchas gracias, doctor Villanueva. Vamos a finalizar con el doctor Ahmed. Como les habíamos dicho, va a ser un mix de las dos últimas charlas.
Okay, Rita, this is the last talk, and then everybody finishes, right? Okay. Everybody is very tranquilo. Tranquilo. How come everyone's so tranquilo? Joe, come on, wake everybody up. Go run around everybody here. Well, thank you for staying around, by the way. I know that there are some people who left. I remember what they look like. Tomorrow I'm going to speak to them, okay? And ask them why they left. We have some more seats over here, just for you. Well, really, it's a pleasure to, again, be back here and speaking. And tomorrow I look forward to sharing some more talks. We're going to be excited about hopefully sharing some 3D videos. We're working on this, right, my friend? Alto's working on that to get it for everybody here. Who knows where this picture was taken? Mexico City, yes. Yes. This is in Toronto, yes, on a daytime, and this is Toronto at night. So I hope you have a chance to visit. It's a very nice city, especially January 25th. Around that time, the weather is perfect for you from Panama, and you will enjoy it. You will enjoy it. Okay, so this talk I made, trying to put it together because we had some, changes from the morning, talking a bit about trauma. So we'll talk a bit about trauma here. Talk about dealing with some of these zonular problems. Now, how many here do some traumatic repair of the anterior segment? Cataract, iris, okay. How many here do eye surgery? Just keep it broad for now, broad. How many know how to examine the eyeballs here? You guys are very difficult. Why is everyone so difficult here? It must be the lunch. Who had dessert? I know you had dessert. Lupa had dessert, okay. Okay, yes, you want me just to finish my talk, right? Get the talk done so you go home, get your credit. So of course, these cases are challenging. The patient on the right, requires some special tools and suturing and maybe another IOL design. While this has a bit of very subtle iridodenesis, a little bit of denesis, that we think maybe a regular ring can work. This is where having some of the newer technologies, we call these capsular tension devices, CTRs, modified rings, and then probably the most important device in all of ophthalmology here, right? Is called the capsular tension segment, CTS. Do you know why it's the most important device? Oh, okay, all right. So this case you see here, you can see the traumatic zonular loss here. It's subtle, it's not a lot. Notice right when we started the rexus, look at the folds in the capsule, the wrinkling of the capsule. This gives us a sign, and look at the folds here, the stria, that this patient likely has zonular problems. So one of the benefits in doing capsulorhexis, if you still do it, some people do femto for everybody, but it gives us some feedback on the capsule and the zonular strength. In this case, which I classified as mild disease, I'm using viscoelastic to viscodissect and separate the cortex from the capsule to prepare for the injection of a capsular tension ring. Remember, this ring works by essentially spreading the forces around the capsular bag, allowing it to support areas where the zonule is weak by spreading the tension around, and a centrifugal force to maintain capsular bag conformity and circularity of the capsular bag. Once we have it in place, we can then effectively remove the lens and the cortex with the minimal difficulty. This case was not a very difficult zonular case, but just having the CTR just gives us an extra benefit of having security that the lens will be well centered in a toric lens and also prevent vitreous prolapse. Now, obviously, these cases we know a regular CTR will probably not be enough, right? By the way, these are some beautiful pictures. Aren't they beautiful pictures? No? Maybe they're a bit scary, right? If you're a cataract surgeon, if you're a retinal surgeon, you're like, yeah, give me this, I want this, let's chop it up, vitrectomize it up, right? I mean, this is particularly a very beautiful lens, eh? Very nice curves on the lens. And these are, of course, where having the right devices are very helpful. These capsular retractor, especially designed to support the capsular bag when zonules are weak. Notice the double suture here, loop, which is designed to support the capsular equator. We also have, of course, the most important device, the CTS, which you see is a partial ring segment with an eyelet that can be used to be supported with an iris hook to support the capsular equator. And of course, we spoke earlier that when we suture these devices in, we like to use a more durable suture. Gore-Tex has been used for many years by the cardiovascular surgeons and by us. And this particular model, CV8, is the smallest bore suture, 7.0 Gore-Tex. This case, you can see, of course, has area of temporal dialysis, a little bit of trypan blue, under viscoelastic, a good rhexis, center of the rhexis on the capsular bag, not the pupil. And these are the MSU retractors. They're very nice and easy to use through a small paracentesis, very much like iris hooks, if we were going to use them. And they can lift up the capsular bag. And the nice thing is they don't hold the bag by the capsular rhexis, they're holding the bag by the capsular equator. And they put tension on the capsular equator to reduce the risk of the capsule coming forward. And there's all the cortex is removed. And of course, once we do this, we then have to remove these now. And they're a little bit bulky to remove, but we basically do it 180 degrees and pull them out through the elbow. And now we have the Gore-Tex suture going through the capsular tension segment, which has been placed in the eye. And this can then be placed in the capsular bag with the suture through it, double-armed, through the scleral groove to suture the segment in place. This will basically hold the bag in place. I almost always will use a capsular tension ring at the same time. This supports the bag circumferentially, and there we have a very nice, perfectly centered lens. Some of these other patients, like this young patient, you see here with a sublux lens, these patients often have very large amount of width of rule cylinder. So I don't like to use toric lenses in young people because they develop against the rule over time, but this patient had a very high degree of cylinder present. You see I've made a scleral groove already. And then, of course, our biggest task is to do a proper capsular rhexis, which, of course, in a pediatric patient who's 3 years old is a bit difficult because the capsule is so elastic. That's why trypan blue is helpful. And also, of course, the lens is decentered a little bit, so we have to basically do a capsular rhexis centering the capsular rhexis on the capsular bag. So with the right viscoelastic, and look how stretched those zonules are. You can see how stretched those zonules are in this case. We then have a nice capsular rhexis done, and we can then place, in this case, the iris hooks first on the capsular rhexis. This is just temporary to hold the bag in place, viscodissection here, and then we slide the capsular tension segment into the eye, and the segment will be used with an iris hook placed upside down through the eyelet, you see there. Joe, look at my cursor, see? See, right? You can do anything you want with it, see? Anywhere you want, yeah, very cool. Now we remove the lens, and we can then get ready to place our sutures through the eyelet, like we showed earlier. The Gore-Tex suture is a long suture needle, and it fits in very nicely with a 25 gauge needle, or we can use forceps to go through the sclerotomy and pull it out if we wish. This is what I like to do, though. There's one pass, second pass, and then we can place our CTR in place as well. CTR goes in, IOL goes in. Toric lens. Now, who does pediatric cataracts here? Anyone do pediatric cataracts? So what's the problem? This patient is going to have PCO. So what do we do? Well, what I always do, my favorite thing, posterior capsular rhexis, yes. And I do not feel a vitrectomy is needed. The reason is because I will do a posterior rhexis and I will push the optic through the posterior rhexis. So now there's nowhere for the cells to grow. There's no hyaloid for the cells to grow over top. There's no capsule for the cells to go over top. So the risk of this patient developing opacification is very low. I am not a fan of doing vitrectomy if I don't need to, or opening up more than I have to. So I find that we have the lens in between the capsule and the anterior hyaloid. It fits in very nicely, and some of you may say, how can you do a capsulorhexis when the CTR is in the bag? Will it not run out? Actually, no, it actually goes quite well. This next case, and I also have the nice centration of the axis because it's well positioned, it will not rotate either. So the IOL haptics are in the bag, the optic is behind the posterior capsule. It's one of my favorite techniques. This next patient you see has very good zonules, and you could argue this patient should be maybe sent to a retinal surgeon, right? No, of course not. The retinal surgeons are busy enough. Those guys don't need to do it, right? This is basically using the understanding of how to do capsulorhexis at the same time as lifting the lens up. You know, residents, we teach you about doing a nice rhexis using vectors, right? No? Maybe? And now we basically lift up the capsule while doing the capsulorhexis using two hands. And you can see again that there's still a few zonules left. There's some kenalog that stains the zonules as well here in this area. And now you see we have the iris hooks placed on the capsulorhexis. Now, yes, I agree. This is definitely maybe a little bit more than we need to really do, right? This is kind of, I don't recommend trying this tomorrow or when you're in the OR again. But I just want to show you that when we really, put our mind to something and we think out of the box and we have the right technology, what we can do. It's amazing. Like, this is really incredible. We can actually preserve the capsular bag. Now, one of my oaths, I have an oath I make when I do surgery. As you know, you can tell my bias. I do whatever I can to preserve the capsular bag, because there's no better place for the lens in the capsular bag. Sure, we suture lenses to the iris, to the sclera, ACIOLs, but there's no better place, no better home than for the IOL to be in the bag. So there we pass our sutures through the segments on both sides, two of them there, and now we have a lens nicely positioned in place there as well. And by the way, I'm not lying about this case. This is not a lie, I swear. I swear to you. I swear to God to you. I believe in God. This patient, maybe like a few months post-op, what's the vision? What's the vision? Uncorrected 20/25. And what's the near vision? J2. So no need for multifocal lens. This is a new presbyopic treatment. Okay? I got lucky, I know. Now, these cases, and it's better to be lucky than good. Now, these are more cases, of course, that require us to really think deeply. These patients not only have visual problems, not only do they have photophobia, but they are disfigured. They are self-conscious. They have low self-esteem. Who in the room has low self-esteem? Put up your hand. Nobody? You guys are all pretty confident. Zubair, I know Zubair, I know. So these patients really require us to think about the visual, functional, biopsychosocial, cultural aspects of our healthcare. We're not just ophthalmologists, right? We're medical doctors. We help people feel better about themselves, right? So these require us, again, having the right instrumentation, having the right technology, the right forceps to help suture these cases. And again, I talked about different ways. This is the McAmid technique. Place the needle through the iris, whatever bite you need. Pull both suture ends. Where are you going? We're not done yet. Hola, hola. Oh, hey, we're not. Who are those guys? What? This is how you treat Canadians? Is that how you treat Dominicans and Mexicans too? Wow. So we pull both sutures out through the incision, okay? Very simple. Then take a micro tire in one hand and loop around the suture. Grab the long end and push it in the eye. It's not a hard thing to do, right? And then you can cinch it down and pull it out and do a locking suture again and cut it. One step ahead of this is intraocular tying. What I showed earlier, we tie sutures in the eye, right? So remember, it's fine, be a good cataract surgeon. But you don't spend residency in your life just to do 20, 25, 20, 50 cataracts. Come on. Right? Or doing retinal detachment. I mean, come on, right? Okay, or vitrectomies. We have to pull ourselves to do special cases. This is what makes us special and be doctors, right? Don't go for the money. Go for the power. No, go for the goodwill, right? This is a young man who's 25 years old. He had injury to his eye. He lost his job. He's alone, depressed. And I told him, I said, amigo, I'm going to get you back to work. Okay? Amigo. This patient is phakic. He's about 20/40, uncorrected. I didn't want to take his lens out. He has accommodation still. So we're going to carefully suture the defect using micro instruments like I showed you here in my hands. We go from right and left hand to pass the needle with one hand, other hand, grab the instrument with either hands. So as eye surgeons, we have to use both hands, not just one hand. We're bimanual surgeons. We want to be careful and use the right approach. Now we pass our suture all the way through. Okay? We will then take the ends into the eye, and we will then do the intraocular tying. Tie the suture in the eye. These are specially designed micro tires to tie the suture, as I was telling you about. And we tie it there, keep a short end in the eye, and then bring the long end back in, create a loop, do a reverse throw like we do outside the eye, and then lock it. One of the important things when we suture in the eye is, of course, using the incisions as a fulcrum, working together with both hands to do the tying. And there we have the suture not tied, and then we cut the suture. And then we have to, of course, put more sutures here, and there are different ways. This is basically using, in this case, the Siepser sliding knot technique, which is another approach, where you basically create a loop of suture out through the common incision, loop around the curved tire, and grab the proximal suture, and leave one suture out to the other end here, and slide it in. Now again, if you've not seen this before, to put it in your mind is not easy. So you can again go to my YouTube channel, and don't forget to subscribe. Right? More subscribers I need. I want to get to over 3,000 subscribers. Right? I'm kidding. And then you slide the knot in. And we do multiple throws to suture the defect there. And now we have closed the suture there. So there's pre-op, there's post-op. And you can see now he has a job, he has a girlfriend, he's making money, you know. He's very happy. Because these patients can be very bothered by glare like this. You know, it really affects your quality of life when you can't go outside and you're always closing your eye and squinting. Like this patient, who is a young woman who had trauma to the eye with a cataract and an atonic pupil. And in this case, she was used to wearing multifocal contact lenses. And she really, really pushed me to say, can I put a multifocal lens in my eye? I said, no. I don't do a lot of multifocal lens in one eye only in young patients. I don't know. I don't find them to be as happy. And then I know I have to suture her pupil down. So I'm not sure if she's going to be unhappy. Then what do I do then for her lens, you know? And of course, with the pupil being small and not reactive, then how will this impact it? So these are all considered. And nevertheless, I'm not a very rigid guy. I said, okay, she seems like she knows what she's talking about. She understands the risks. So I'll go ahead and put a multifocal lens in. I chose to use a multifocal toric. This is a pupil independent, so it does not rely on the pupil for its refractive power for near, and basically divides the light 50-50, right? This is the Tectus multifocal. And toric lens goes into the eye, remove the viscoelastic, center the lens on the Purkinje image, and then we have to suture the pupil. So this is one of my favorite techniques as well, basically, which is the pupillary cerclage. This is using, again, the tenoproline suture. And notice how important the microforceps is to feed the iris to the knot, to the needle, to feed the iris to the needle. And this is, by the way, topical anesthesia. It works quite well in my experience, as long as the patient can lay down for the procedure. And in this case, we're going to place the sutures along each axis. We're going to divide it up into 4 parts and pass it in. Now I'm switching hands. My left hand's holding the needle driver. My right hand's holding the Forceps. Notice the needle does not do the work. The forceps are bringing the pupil iris to the needle. Because it's hard to move up and down the needle in the anterior chamber in a very small space. So we're going to go all the way around, and now we will tie our suture outside the eye and slide it into the eye like we showed earlier. Oh, thank you for coming back. Thank you. Gracias. Gracias. Now we can continue the talk. We didn't talk for 20 minutes because you left. And now we basically can lock the knot in place. I like to make the pupil about 3.5 millimeters. This is a good balance between mesopic and scotopic, and our retina surgeons don't like us because they like to get a big pupil, but they can still look around with depression and a Goldman lens, and if they have to do surgery, they can use a biome, a wide-angle view system, and they usually can do okay with this. But if they don't, I just tell them, cut the suture or put iris hooks in. And there you see her post-op between the eyes, and you can see that unfortunately this eye is not perfect. I'm sorry, I apologize. Forgive me. And she posted on Facebook, you know, she posted my name on Facebook. She came to see me from Hawaii, and it worked well. This young woman came to me. She's a 4-year-old girl who came, 5-year-old girl I think she was, from parents who were very upset because at the daycare where her child was, they had scissors, and she's holding the scissors like this, and it went into her eye. She had primary repair, but of course her pupil is very distorted, and she did not tolerate cycloplegia as well. And her mother actually was very concerned about her appearance. You can see the fibrosis from the capsular bag to the cornea, and the lens is a bit tilted. This patient has about 5 diopters of regular cylinder as well, corneal cylinder, but the rest of the zonules were okay. I like to put some trypan blue under viscoelastic so it's nice and controlled, just a little bit in. Do our capsulorhexis, avoiding the area of the trauma, and then do some viscodissection. This is a soft lens, removing it, putting a toric lens in, and then we have to look at the iris. This is basically the 23 gauge cautery. I mentioned this today to you guys in the OR, remember? This cautery I use on the iris to cauterize bleeding if it happens or prevent it, but also look at, it's very nice to be able to manipulate the pupil. I have to bring the pupil up, right? The pupil is so small on the side, I have to bring it up. So rather than cutting the iris and it's very irregular, this cautery is very helpful to essentially do a pupilloplasty effect. And once we do this, we have the iris in better position. And now, watch, what am I doing here? I'm cutting part of the capsular bag with the gonio lens because I want to release the traction up. And the lens is in the bag now, so I feel safe to do this. I also need to, of course, suture the iris inferiorly here. And we will cut the iris here to bring the 2 leaflets forward. Look, see, I'm cutting the attachment, the synechia here. And then we will basically suture this young girl's pupil together using this, again, suturing with the tenoproline, passing through the eye, bringing both ends outside the eye, as you saw, and then you saw that already, loop the microtire, I call it a microtire, and then push it into the eye, slide into the eye. Very straightforward, as you saw. And this requires, I think, maybe 4 or 5 sutures, back and forth, all the closure. Oh, the pupil looks teardrop. Yes, it is, because there's iris tissue missing. But that's okay, right? No, it's not okay. We should be perfectionists, right? We want to repair that. We can bring the cautery now. Look at the cautery. Look how nice it's nice to be able to reshape the pupil. If I didn't have the cautery, then I wouldn't be able to reshape the pupil. And this will last a very long time. I have not seen it retract after treatment. Now, this eye will have more inflammation, of course. Treat them with steroids. And we now have a better shaped pupil here at the end of the case. And that's the position of the eye, pre-up, both eyes there. Now this eye also had a problem with because this patient has trauma again, they have missing iris. I don't know if I can suture it together. The cataract is, white. What's the capsular bag like? Can I use the capsular bag? There's nothing there. So I didn't know what to expect here. There's some capsular fibrosis, but the one good thing is the lens is soft. So basically, I can essentially remove most of the lens, as you'll see. The capsulorhexis we'll make a bit oval, small. We'll aspirate the lens material by the... By the way, This is a very expensive technology. You know what it's called? A 27 gauge cannula. It's very cheap compared to some of the other technologies out there. And I'm just basically using it to aspirate. I can use a silicone needle if I wanted to as well, but just to aspirate the lens material. And now we evacuate the capsular bag. I put a CTR in. See, look at the adhesions here. I didn't know what to expect, but I need that bag to be expanded. So I put a CTR in, carefully to put it in the capsular bag. And I didn't know what to expect here, really. I thought maybe I had to put an iris prosthesis in perhaps here. And now we have it in the bag. I'm going to move this over here. And I thought, okay, this is a good option for CTS, right? No, it's not. How do you know that, Lupe? How do you know it's not? You know it. Okay, well, I passed my sutures. Okay, this is looking good. I'm going to be fine. I put it in the bag, and watch, when I pull it, look what happens. The CTS torques. It's coming out of the bag because there's too much tension there. So, look, I cannot use it now. So that sucks. So I said, okay, let me take it out. Let me leave the suture in there. What am I going to do? How am I going to fixate the capsular bag there? Well, what's my favorite thing to do? Posterior capsular excess. Why? Well, watch what I'm going to do. I'm going to make a peripheral, very small posterior capsulotomy. And this way, I basically have an opening there. I will then take my suture and put it through the posterior capsulotomy here, around the capsule in the CTR, and now I'm pulling the entire bag over. So now it's centered, right? I had never done a case like this before, right? I mean, this case doesn't happen every year even, or every week, right? But it's about how our mind thinks. How do we improvise? Now one-piece lens goes into the capsular bag, and then we have to decide, what about the iris? Well, I can suture the iris together, like I showed earlier, but the key point here I want to show you is there are still iris adhesions into the angle. So what I need to do here is release the synechia from the angle by pulling it and releasing it very carefully. It's very thin, I know, but I'm going to just tease it away from the cornea here to create that flap. So now I have a flap. Look at that, see? I'm going to put the flap together to suture it to the resisting iris. So this is like putting a puzzle together, right? This is really a lot of fun, actually, because you really have to kind of improvise here, and it's like putting together an art piece. And what we do is like art. So multiple sutures there, multiple suture passes. You see I put 4 sutures here together, 1 here, and now we see the pupil come together, and we've taken him from what he looked like before, remember what he was before, to now. So this is about art. Thank you. Maybe I should stop now because everyone clapped, right? Well, I think we have to finish, right, Mickey? We finish now because what we'll do is tomorrow we will show more videos and also on 3D as well, right? So we'll keep that for tomorrow. Everybody's been so nice staying here and listening and not putting your hand up. So tomorrow you'll put your hand up. So thank you again, Mickey. Thank you, Rita, as well. Thank you for inviting me. Sam, thank you guys. You guys are wonderful hosts. And I look forward to seeing you tonight, tomorrow, wherever it's going to be. And thank you to all my faculty as well. Thank you.
Thank you. Creo que todos hemos disfrutado de esta cirugía. Mañana el doctor esta noche va a dormir temprano para estar mañana a las 7 comenzando. Desayuno con los expertos. Vengan más temprano a las 7 porque el desayuno va a estar puesto de las 6:30 y el doctor va a estar aquí a las 7. Así que los invito a que, así como él sea puntual, nosotros también seamos un poquito puntual. Vamos a tener también mañana la oportunidad de ver las cirugías en 3D. Eso va a ser un poquito pasado al mediodía. Así que yo creo que va a ser un día interesante. Duerman temprano hoy. Los invito también a que todas estas pláticas están ahora mismo ya en el canal de YouTube. Los pueden ver, los pueden revisar más tarde, aquellos que estaban cansados. Y les recuerdo que mañana también tenemos en la noche la clausura con cena y baile y diversión. Así que Los invito también a que se suscriban, se inscriban en el chat que les mandé, porque necesito ahora mandar finalmente el número de las personas que van. Muchas gracias por su atención y creo que ha sido una experiencia enriquecedora para todos nosotros. Así que nos vemos mañana.